on the wine internal side by the peritoneum, and the kidney, right kidney, a little bit lower than the left, goes from the right side pressing by the liver, and the upper pole of the left kidney is located at the level of the middle of the 11th thoracic vertebra, and the upper pole of the upper body of the right kidney reaches the lower edge of this vertebra. It's important for us because during examining during X-ray with using contrast, we can separate it with using normal anatomy localization or it's a nephroptosis and lowering and unloading of the kidney pole. The lower pole of the left kidney lies at the level of the upper edge free of the lumbar vertebra, and the lower pole of the right kidney corresponds to its middle. And as you can see at this picture, it's a projection of the kidney in the thorax and abdominal cavity. The 12th rib intersects the posterior surface of the left kidney almost in the middle of its length, and the right one is close to its upper edge. Kidney, or renal in Latin, it's a paired excretory organ that forms and excretes urine, the main function. Kidney has a bean-shaped form, and the length of each kidney is a ratio between 10 and 12 centimeters, and the width is 5-6 centimeters. The thickness is 3 and 4 centimeters. The mass of each kidney depends from the mass of the person, and also in the ratio between 150 and 160 grams. The surface of the kidney is normally smooth. In the middle section of the kidney there is independent, the renal gate, in which containing of the main renal artery, it's a number 3 on this picture, and nerve flow, and the renal vein, as you can see, and lymphatic ducts, now shown in the figure, and all these structures form the renal portal. The renal pelvis is also located here, which passes into the ureter. On the section of the kidney, we can determine with you 2 layers, which will clearly visible: cortical layer and cerebral layer, as you can see. And in the tissue of the cortical substance, there are renal or Malpighian bodies, the main construction, and in many places, the cortical substance penetrates deep into the cerebral mass in the form of radially located renal columns that divide the medulla into renal pyramids. And look there. Renal columns, which penetrated in the medulla of the ram, and which consisting of straight tubules forming a nephron loop, and from collecting tubes passing through the medulla, and we will discuss it some later. The tops of each renal pyramid form the renal papillas. It's the number 4 pyramids. Renal papillas, like an upper part, with a hole opening into the renal cups with the urine. The later merge and form the renal pelvis, which then passed into the ureter and continue on the diuresis. Renal caps, pelvis, and ureter make up the urinary tract of the kidney, and on top of the kidney is covered with a dense connective tissue capsule, and the ren protective from inflammation, from trauma, this dense connective tissue capsule. Next grade of the urinary tract, its urine bladder, is located in the pelvic cavity and lies behind the pubic symphysis, and in men and in women. When the bladder is filled with urine, its tip, its upper part base, protrudes above the pubis and comes into contact with the anterior abdominal wall. In women, the posterior surface of the bladder is in the closer contact with the front wall of the cervix and vagina, and in front, while in men it's adjacent to the rectum. The female urethra is more shorter, so a ratio between 2.5–3.5 centimeter in duration, and the length of the male urethra is about 16 centimeter. And its initial or prostate part of the female urethra passes through the prostate gland, which has important pathophysiological significance for the passage of urine from the bladder in patients with hypertrophy or a tumor of the prostate. But from another side, the structure of the female ureter, it's a host factor for more quickly and more damage of development of urethra, cause shorter, more wider, and more closer localization with the rectum and vagina. You can separate it on this picture. On the picture A, it's a structure of the female urethra. Number 1, it's a gallbladder. Number 2, it's a utera, and very close contact and sometimes inflammation, and the pain syndrome can't separate it from the organs of the pelvitis. Next, it's neighbor organs of the rectum. Number 4, it's a urethra. Number 5, it's a vagina. Number 6, it's a cyst of the rectum. So, and if we look at this it will be understandable for you that the shorter and intact anatomy of the female urethra, it's already a host factor for developing inflammation. Look to the picture B, it's a structure of male urethra, and the main pathophysiological mechanism and pathophysiological point there, it's a prostate gland, because the initial part of the urethra going through this gland. And in case of hyperplasia or tumor of the prostate, the first complaint from the side of the patient, it will be some problems with the diuresis. The main structure and the main functional unit of the kidney is the nephron. Each nephron consists of a renal or Malpighian body and a tubule. The latter is conditionally divided into 3 sections. The main 3 sections, like a proximal convoluted tubule on the first order, next Henle loop, and distal convoluted tube of the second order. In other terms, the Henle loop consists of a thick downward segment, which is a continuation of the proximal convoluted tube, thin descending and ascending segment, a thick ascending segment which passed into the distal convoluted tube, and the latter flows through the connecting tube into the collecting tube, which is now longer part of the nephron, and into which the distal tubules of many nephrons open. It's the structure of the nephron, which separated for 3 parts: proximal part, Henle loop, and distal convoluted part. And Henle loop consists also from the 3 main structures. The renal or Malpighian body consists from a glomerulus and a Shumlansky bone capsule. And look, you can see it on the screen. Glomerulus, it's in the center, and Shumlansky bone capsule, it's practically covered the glomerulus from all sides. The glomerulus or glomerula is a vascular formation that containing about 50–60 capillary loops starting from the braining arterioles and collecting into the carrying arterioles. The latter is approximately 30% already bearing arterioles, which creates a relatively high intracapillary hydrostatic pressure. And as you discussed in physiology, the level of hydrostatic pressure in glomerula is a very important factor for filtration of the primary urine. Shumlansky bone's capsule has the shape of a ball and you can see it in the picture, inside of which there is a glomerulus, and it consists in the stone of an inner visceral leaf, which adhered tightly to the wall of the glomerular capillaries, and the outer and parietal leaf, between which there is a microscopic cavity of the capsule. And primary urine is filtrated into the capsule cavity, which then enters by the tube. Primary urine from the inner and from the external inners. The main feature of the blood supply of the renal or cortical nephron is that the interlobular arteries breaks up twice into arterial capillaries. And you discuss it. This is a so-called wonderful kidney net. After entering the glomerular capsule, the brining arterioles breaks up into glomerulus capillaries. Look at this picture. There is glomerula, there is Shumlansky bone capsule, which then combine again to form the glomerular efferent arteriole, and after exciting the Shumlansky bone capsule, it again breaks up into capillary, wonderful net, densely brilliant the proximal and distal section of the tubules, as well as the Henle loop, and when providing them with the blood. The second important feature of the blood circulation in the kidney is the existence of two cycles of blood circulation in the kidney, large or cortical cycle of circulation and small or juxtamedullary, corresponding to two types of nephrons by the same name, cortical and juxtamedullary nephrons. And this separation in blood supply of the kidney for cortical and for medulla or juxtamedullary cycle of circulation helps the kidney containing blood supply during hypovolemia. About nephrons, cortical nephrons, those glomeruli located in the cortical substance of the kidney, have a relative short Henle loop that does not sink deep into the medulla of the kidney. Look, cortical. As mentioned above, the efferent arterioles of the cortical nephrons form a second network of arterial capillaries around the tubules of the nephron, and the glomeruli of juxtamedullary nephrons are also located in the cortical substance primary of the kidney, but are somewhat closer to the cerebral lower and like a shifting to the medulla of the kidney. The Henle loops of these nephrons sink deep into the medulla of the kidney, reaching the deticus of the pyramids, and the arteriole carrying out juxtamedullary nephrons does not break up into the second capillary network, but forms several straight artery vessels that go to the tops of the pyramids, tops of the upper part, and then forming a loop return back to the cortical substance in the form of the venous vessels. Direct vessels of juxtamedullary nephrons located next to the ascending and descending section of the Henle loops, and being essential elements of the contracurrent system of the kidney, and playing an important role in the process of osmotic concentration and dilution of the urine, osmotic pressure and osmotic density. Under physiological conditions, 55–90% of the blood circulated along the large or cortical cycle, and only 10 and 15 in the small or medulla cycle of circulation. In some pathological conditions, the bulk of the blood begins to move in a small cycle, a shorter renal path, for example, and in this case, juxtamedullary blood circulation becomes a kind of shunt, through which most of the blood does not enter the cortical the kidney, which can cause ischemia of the cortical substance and even the formation of necrosis in it. But in the same time, it's continuously normal circulation in the medulla and help to save the juxtamedular nephrons. As you can see, it's a structure of the juxtamedular nephrons, which like a shifting in the down in the medulla of the cortex. On this slide, you can assess also glomerula and von Shumlensky capsule. And I told you that the hydrostatic pressure play important role in the filtration pressure. Also, filtration pressure of the glomerula of the urine depends from the lumen of the efferent and afferent arterioles. And this difference in the pressure, from this difference depends the level of the filtration pressure and the level of diuresis. About the main compliance patient with kidney disorders. Surely we start from the pain with glomerulonephritis itching. There is a feeling of heaviness from the both sides of the lumbar region. In case of pyelonephritis, it will be the same in the zone of the projection of the kidney to the posterior back side. In acute pyelonephritis, intense pain is present in the affected side, more affected side. These pains result from inflammatory swelling of the renal parenchyma and sprains of the renal capsule. In fact, it's practically the same situation like with the lungs, because in the parenchyma of the kidney, no any nociceptors to reagate it to inflammation. But during inflammation, volume of the parenchyma increase, ureastasis, which also increasing the volume and started to press into the capsules, and capsule, this density covered, which covered the RAN, started to impress from the internal surface and can reagate it and can stimulate it nociceptors, and it's a mechanism of development pain syndrome in case of inflammation. More often, pyelonephritis can be from the both sides, can't be from the both sides, and pyelonephritis, it's a pain syndrome only from the one affected side. But sometimes it's possible that it will be from the both. So during an attack of urolithiasis or present the stone in the pelvis, in the ureter, the patient has a sharp pain in the lumbar region with slightly radiation down during the direct of the ureter into the ureter and genitals. And also it's very significant for patient with kidney disorders, with inflammation kidney disorders, cause stone in the ureter. It's the first moment of development urostasis and first moment of the development inflammation, and surely this pain can be radiated by the direct of ureter. Pain occurs due to a spastic ureteral contraction as well as a urinary retention in the renal pelvis and its extension. And usually the pain in case of ureter or ura or kidney lithiasis taken like a colic character, and we can call it renic colica. So localization of the pain in the lumbar order, in the lumbar region from the both sides, or it depends from the side of inflammation, can radiate it by the direct of the ureter, by the direct in the pelvises, and also can take like a spastic character. Irradiation of pain is due to the fact that is the corresponding sequence of the spinal cord, no, it's logical, and nerve fibers that carry sensibility impulse from the kidney, ureter, and genital space in the immediate vicinity. In acute pyelonephritis, cause in norma kidney surrounding by the lipid tissue, inflammation in the perinephric tissue and perinephritis, inflammation in the perinephric space, the pain is more intense on the affected side. pain in the lower abdominal occurs with cystitis or inflammation of the bladder. So if inflammation of the kidney is located in the lumbar region, inflammation of the gallbladder more in the pelvis inside the abdominal. It's a pain. Next, complaints that can accompany disease of the urinary system is a dilation of the formation and excretion of the urine. And practically in all cases, the patient will tell you about some changes. The excretion of urine after a known period of time is called diuresis. In diuresis, we can separate it like a positive and negative. Positive diuresis, if the patient excreted more urine during the day than drinks fluid, and we need to count all fluids, all liquid, not only water, and negative with an inverse ratio. Positive diuresis is observed with the convergence of edema, taking diuretics in some other cases, non-diabetes mellitus. Negative diuresis is observed with a delay in the body's fluid, with edema, and with excessive secretion through the skin and lungs in a hot and dry climate in a healthy person. Some urinary disorders. And the first one is polyuria. It's abundant urine or production of the urine or diuresis more than 200 mm per day can be due to many reasons. First of all, it's massive water load leading to tissue overhydratation and according by the normal mechanism described above to the separation of the large amount of the urine with a low content of the osmotically active substance and low urine density. Low urine density in this term we can interpret it like a hypostenuria. It means that decreasing the normal density of the urine. The second cause of polyuria can be the use of osmotic diuretics. When the concentration of osmotically active substance in the blood, plasma, and in the tubular fluid increases, as a result, the mandatory absorption of osmotically active substance in the proximal tubules decreases. Accordingly, the quantity and speed of the movement from the tubular fluid in the loop of the Henle and the distal tubules increases. This in turn prevents the formation of an osmotic gradient and leads to a decrease in the optional reabsorption of water in the distal tubules and collecting tubes. This condition is called osmotic diuresis. Next cause of polyuria can be by taking diuretics, which cause blockage of potassium reabsorption in the tubules and accordingly reduce passive reabsorption of on the proximal and distal tubules, also contributing to osmotic diuresis. Severe impairment of the renal function with a sharp decrease in the ability of the night to create a sufficient concentration gradient of osmotically active substance in the brain substance and thus to concentrated urine. This picture develops in a chronic kidney disease when more than 60 and 70% of the nephrons cease to function. In other disease accompanied by dilation of the process of creating filtration in osmotic concentration gradient and concentration of urine. For example, diabetes insipidus, in which a decrease in antidiuretics hormone secretion leads to a sharp decrease in the optional reabsorption of water in the distal tubule section and collection tubes. Pyelonephritis, with a violation of the concentration gradient due to inflammation lesion of the brain layer of the kidney and collecting tubes, which helps to reduce the accumulation of osmotically active substance in the brain substance of the kidney. What we have to remember with you, that in dilation of the concentration ability of the kidney in patient with chronic renal disease, a lot of urine is separated. It's polyuria, including its first initial stage, including at night, and we can call it nocturia and nighturia. It has a hallow specific gravity or density hypostenuria, which persist for a day, isostenuria. So persisting during all day, not separated by the nighttime and daytime, low density of the urine, we can call isostenuria. So nocturia, it's more large diuresis, more high diuresis during the night. Polyuria, it's increasing in large in the amount, the volume of the diuresis. Hypostenuria, decreasing the density, and isostenuria, it's proceeding decreasing density of the urine during all day. Next complaint, it's oliguria, a decrease in the amount of urine which excreted per day, and can be caused by both liver problem, limitation of the fluid intake, for example, increased sweating, profuse nose, indominant vomiting, all problems which lead into losing the volume of circulation blood. And dysfunctional kidney in patients with glomerulonephritis, pyelonephritis, and uremia. Pay your attention that oliguria due to impaired renal function in case of chronic kidney disease or acute kidney injury in most cases is combined with a decrease in urinary excretion of osmotically active substance and a decrease in the specific gravity of urine. Oliguria in patients with preserved renal function is accompanied by the separation of urine with normal or increased specific density. Next type of complaint, it's anuria, is a sharp decrease less than 200 and 300 millimeters per day, or a complete cessation of urine output at all. And there are two types of anuria, the main two types of anuria. Secretory anuria, which will caused by pronounced dilation of glomerular filtration, which can be observed by the shock, hypovolemic shock, acute blood loss, in fact it's also hypovolemic shock, uremia. And in the first two cases, glomerular filtration disorders are associated mainly with a sharp drop in filtration pressure in the glomeruli, because filtration pressure depends also from the level of the total arterial blood pressure. And in case of decreasing BP, it's leading to decreasing the speed of filtration urine and the pressure of filtration. And in the later case, with the death of more than 70 and 80 of nephrons, cause it's leading to shifting circulation cycles in the medulla and losing some of cortical nephrons. It's secretory anuria. Then the problem will be exactly with the filtration of the urine in glomerulus in the kidney. Excretory anuria or ischuria is associated with impaired urine separation through the ureter or with a decrease in the function of the bladder with preserved kidney function. So excretory anuria, absolutely normal preserved kidney function, but problem with excretion or excretion of already titrated urine through another part of urinary tract. And the cause of excretory anuria can be paralysis of the muscle of the bladder, which leading to the impossibility of its normal contraction and emptying. It's possible. And how we can check in this case with you it's anuria or not? We can make a percussion of the urine bladder and confirm the presence urine in the bladder. So it means that filtration is normal and we have the problem with excretion. Next cause, an increase in the size of the prostate gland, the most common cause in case of hyperplasia or adenoma, or in case of tumor growth in the prostate gland, which compression of the initial part of the ureter. And it's important pathophysiological mechanism of anuria, and we discuss it in the moment of discussing anatomy. And the next cause can be urethral structure, which also only blocked and closed the way for excretion of the urine. Remember that the urinary urination reduction is observed with a decrease in the daily urine output or oliguria, for example, in acute and chronic glomerulonephritis or uremia, the formation and intensification of edema of any origin due to fluid retention in the body, and significant extrarenal fluid loss, intense sweating, indomitable vomiting, and diarrhea. Remember that urinary retention due to a violation of its excretion is called ischuria, and its main separated features is an increase in the size of the bladder, which is easily to detect by percussion of the urinary bladder. Next complaints of the patient with kidney disorders, it's polyuria, increase the time of urination. It can be observed in case of with an increase in the daily urine output in case of polyuria by all causes which we discussed, during the convergence of edema of any genesis or with the use of diuretics. It's the main effect of diuretics, with inflammation of the bladder in case of cystitis or inflammation of urethra, urethritis, which leading to stimulation and leading to increase in time of urination. In the last two cases, the sensitivity thresholds of the corresponding receptors is significantly reduced, and even a slight extension of the wall of the gallbladder with a small amount of urine, which is a preceding sign, go to reaction to lead to its emptying. Thus, unlike other causes of polyuria, like cystitis and urethritis, urine is often separated, but in small portions. Small portions due to orientation, increase in sensitivity, and it's not real polyuria, but we can explain it like a polyuria, increasing the time of urination, not the volume of diuresis, the time of urination. Stranguria or pain and pain during urination is also a very common sign of inflammation of the bladder and or urethra, and usually combined with polyuria. Stranguria sometimes can be specified like a sign of pyelonephritis, but more common it's compliance with the inflammation of the urine bladder and ureters. The pain in this case is localized in the lower part of abdomen, above the pubis, and is accompanied by a cut in the urethra. It should be remembered that in case of inflammation of urine bladder, pain usually occurs in the end of urination, that is with the maximum reduction in the bladder. With urethritis, pain usually appears during urination and often persists for some time after urination. So, urine bladder pain associated in the end moment of urination in case of urethritis, and inflammation of urethra during all urination, and can identify some minute after urination. What we have to remember, that with cystitis and urethritis, urine is often separated, half like urea, and in small portions, polyuria, which is accompanied by pain and pain during urination. Urethritis and cystitis identify with polyuria, increasing times of urination, and associated with developing pain during urination. And we can separate it and during all and after. Some additional complaints from the side of the patient, which also can be complaints in case of renal disorders. Headaches, dizziness, and pain in the heart observed in the kidney, which are accompanied by a significant increase in blood pressure. and in fact general compliance. And when we discussed with you arterial hypertension, we discussed with you that we can separate it with you secondary arterial hypertension which contact with kidney disorders, and we separated it also by two types, parenchymal and which depends from the position of artery, kidney artery. Like the general signs can be reduced vision. Itching is caused by irritation of the skin receptors during collection of the protein decomposition products in case of chronic kidney disease. Diarrheal disorders, loss of appetite, dry and unpleasant taste in the mouth, nausea, vomiting, diarrhea. It's also a sign of chronic kidney disorder in case of increasing the amount of urea and creatinine, like a product of metabolism of proteins. Next, complaints of a general nature in patients with kidney disorders. Weakness, malaise, loss of memory, performance, poor sleep, sleep disturbance, fever. Fever, it's a common in patients with acute pyelonephritis or exacerbation of the chronic. Usually fever, it's a sign of inflammation, main localization. Short-term, up to 1 day fever or prolonged low-grade fever of the wrong type may be the only clinical manifestation of latent forms of the chronic pyelonephritis. What's interesting that the fever which contact with inflammation and pyelonephritis usually preserved during night time and increasing during night time, cause in the lying position blood is supplying of the kidney increasing, and it's increasing inflammation process due to growth of the bacterial floors. We continue about examination of the patient with kidney disorders, and we need to pay attention to some features which we can find during collection of anamnesis dates. We need to ask about the onset of the disease. Maybe the patient know about communication with the infection, the presence in the past some urinary system disease, acute pyelonephritis, acute or chronic cystitis or urethritis, it's already host factor, or symptoms which suspicion for this disease, dysuria, edema, hypertension, pain in the abdominal lower back, and reminiscent of renal colic in case of stones, toxic chemicals, pharmaceutical, non-steroid anti-inflammatory drugs taken nephrotoxic action, household, some production can cause interstitial nephritis. Pregnancy can be associated with the development of pyelonephritis in pregnant women, as well as nephropathy pregnant. We need to pay attention by the nature of this disease, gradual development of the disease in typical or chronic diffuse glomerulonephritis or renal amyloidosis, relapsing with periodical exacerbation and remission, typical and chronic pyelonephritis, but often occurs in chronic diffuse glomerulonephritis. The reasons for relapse: streptococcal virulent infection, subcooling, fatigue, overcooling, pregnancy, or prolonged use of medication for other chronic disease which take nephrotoxic action, maybe some antibacterial drugs like aminoglycosidium. Clinical manifestation, dynamics of the clinic, when and what sequences were compliance of the patient, spent treatment and its effects, delayed reasons about last exacerbation. Also, we need to take anamnesis about vida of the patient, life of the patient, clarify the risk factors for kidney disease, frequent exposure to cold, living and working in a cold room or in cold condition or outside, drafts, walk on the street, bone disease in the past, to pay attention to genital diseases, tuberculosis, collagen disease, presence diabetes mellitus, blood disease, some chronic suppurative disease like osteomyelitis and bronchiectasis, cause it can lead into chronically autoimmune inflammation and due to mechanism of circulated immune complexes. Also, usually we need to pay attention to professional history to find out from the patient whether his work is related to prolonged walking, reading, lifting large weight that could affect by the cause of urolithiasis and contribute to bouts of a colic. We need to ask and pay attention by heredity causes plays an important role in the development of kidney disease, such as anomalies, urolithiasis, and either amyloidosis of the kidney and the liver. About examination dates, edema is one of the earliest and most common symptoms of many kidney disorders, and to the most important mechanism of development edema, it's a decrease in plasma oncotic pressure, like a result of a decrease in the total amount of the blood proteins, including albumin. Next, increased capillary permeability, like a result of increased activity of hyaluronidase. Third, it's activation of the renin-angiotensin-aldosterone system that occurs with renal ischemia, more precisely with a decrease in pulse dilatation in the renal glomerulus-bearing arteriole, and a decrease in aldosterone secretion leads to an increase in facultative reabsorption of sodium and potassium. A decrease in glomerular filtration in case of severe kidney damage, not shown in the figure, as you can see. So, first of all, it's a decrease in the level of oncotic pressure, and these points we can explain by the nephrotic syndrome, by the losing of the total protein fraction, including globulin and albumin. Second one, increased capillary permeability, like increasing intracapsular pressure, and activation of renin-angiotensin-aldosterone system, like a compensatory mechanism. Finally, with the formation of edema due to the release of water from the vascular bed, the stroke volume and the volume of circulation blood decrease, hypovolemia develops, and which will lead to irritation and stimulation of juxtaglomerular apparatus, volume receptors, and increasing secretion of antidiuretics gammos and aldosterone. All these points leading to increasing retention and leading to increasing general blood circulation to increasing injection fraction. The role of each of these factors in disease of the kidney are different, but so in case of glomerulonephritis, the place in the formation of edema belongs to a dilation of the penetrability of the vascular wall and activation of renin-angiotensin-aldosterone system. In case of developing nephrotic syndrome, a decrease in plasma oncotic pressure due to losing the total globulin. In the several cases of uremia or poisoning with the salts of heavy metals, it's also possible a sharp decrease in glomerular filtration, so-called injection edema or shock edema. Especially significant and widespread edema appears in the nephrotic syndrome, and it's a absolutely clinical symptom, which includes 4 main signs. In some literature, you can find 5 main signs. First of all, it's pronounced edema, predominantly hypoproteinemic in nature, and in several cases, edema till the anosarca, so total edema or pronounced edema. Pronounced proteinuria more than 3 and 5 grams in general urine analysis or during routine daily proteinuria. Hypoproteinemia, then the total protein fraction less than 60 milligram, and the fraction of the albumin less than 25 milligram by the biochemical analysis, and hyperlipidemia, like a compensatory mechanism from the liver. So edema, proteinuria more than 3 and 5, hypoproteinemia, hypoalbuminemia, and dyslipidemia or hyperlipidemia. What we have to remember with you, that the nephrotic syndrome in adult patient in the vast majority of cases is not an independent disease, but only accompanies many primary and secondary disease with the renal disorders. And nephrotic syndrome, we can separate it with you like a primary and secondary. Primary, absolutely contact with the damaging of the glomerula, and in most fraction it's glomerulonephritis. And in case of secondary, it's secondary reaction via in other problems. It can be secondary nephrotic syndrome on the base of background tuberculosis, neoplastic forms, bacterial endocarditis, lupus nephritis, and so on and so on. It's a typical condition of the patient with nephrotic syndrome. And in the first semester, we discussed with you special phases during examination, and it's specifically facies nephritica. Pale, edema on the face, pale, pallor. Also, I want to discuss with you some difference in the edema syndrome, because we discussed with you edema in case of heart disorders and heart failure, and more often mechanism of development heart failure edema contact with increasing hydrostatic pressure. But on the case of kidney disorder, more often edema contact with decreasing oncotic pressure, losing total protein fraction. So, and we can separate it only clinical with you, edema, renal edema, and cardiac edema. Edema, earliest localization. In case of renal edema, it's on the face and facies nephritica, pale, pallor, more often in the morning. About cardiac edema, primary localization on the feet and more often in the evening. If we return to this discussion, more often on the feet cause its normal gravity, that liquid going from the up to down, cause collect during the day, manifestation on the feet in the evening. Renal edema, manifestation on the face, more often in the morning. Next, localization in the later stages of the disease. About renal edema till the inner circle, total the body, face, thoraces, lower extremities, upper extremities, depends from the level of hypoproteinemia. Cardiac edema started from the feet and also can go until the inner circle, including hydrothorax, including ascites. In both cases, it can be. Color of the skin, in case of renal edema, it will be absolutely pale and pallor. In case of cardiac edema, more associated with acrocyanosis, like a sign of patient with heart failure. Some moments about examination of the patient. It's not very difficult because no many manipulation with the examination. Examination of the kidney and urine bladder. Examination of the lumbar region can sometimes reveal a slight reddening of the skin, some soreness during palpation, a particular sensation of fluctuation in case of inflammation. These signs are characteristic of suppuration of the perinephric fibers or paranephritics and attendant and involvement paranephric problems. When examining the area of the bladder above the pubis, a bulging can be detected, which indicates an increase in the size of the urine bladder. Only visual examination. During palpation, the kidney can be palpated by two hands by manual palpation in the position of the pale lying on his back, as well as in upright position. And on this picture, you can find the methodic of palpation of the kidney from the right and from the left side through the anterior abdominal wall. And surely we can separate it with you like usually 4 moments of palpation. First moment of palpation, the palm of the doctor's left hand is placed on the lumbar region and some pressed the kidney to direct of the anterior abdominal wall, and the bent fingers of the right hand are set under the costal arc lateral to the outer edge of the rectus abdominis muscle, through the rectus abdominal muscle edge. Second moment, during inspiration, move the skin down with your right hand and create a skin fold. Third moment, during exhalation, the right hand is immersed more deeper into the abdominal cavity and the left hand seeks to bring forward the area of the corresponding flank. And the fourth moment of palpation, during a deep breath, when the kidney goes down, then try to grab the kidney between two adjacent hands and try to catch in this kidney. And if the success, usually only when the kidney is enlarged or dropped, they slide down with the right tilting hand down, and it's possible to get an idea on the consistency of the organs, the nature of the surface of the kidney, and its pain. In fact, in healthy person, we can't palpate it with your kidney, but in case of nephroptosis, it can be heredity, it can be due to losing the weight. The kidney will be some pronounced allow in the abdominal cavity, and we can palpate it, this kidney, more rigidity kidney than in normal. Also, in disease of the kidney and urinary tract, the presence of so-called pain points can be detected during examination. On the front surface of the abdomen, we can separate it with you, and you can take it to the picture, two ureteric points. The upper ureteric point is at the intersection of the vertical line running along the outer edge of the rectus abdominal muscle and the horizontal line passing through the navel. And the middle ureteric point is 1/3 on the distance from the anterior midline to spina iliaca anterior superior. So the upper ureteric points and the middle ureteric points. From the back side of the chest, in the lumbar region, there are two more pain points. The costal vertebra point is localized in the corner which formed by the 12 rib and spine, and the costolumbar points which located at the intersection of 11th rib and lumbar muscles. What we have to remember that the shortness in the ear or area of the ureter points is detected with lesions of the ureters, for example, in there are stones in them, and in the area of the costovertebral and costolumbar points of kidney disease. So examination, palpation, percussion. Percussion of the region of the kidney is carried out in the upright position of the patient. Edges of the palm of the right hand inflict abrupt strokes on the back of the palm of the left hand, as you can see in the picture, located on the lumbar region. So one your hand you put by the projection of the kidney, in other hand by your end you making a taping or stroke by another hand. In the patient, in the same times notes pain, they speaks, and we can assess it like a positive symptom of Posternetsky. Posternetsky is a synonym of the author of the symptom, positive or negative symptom of Posternetsky or symptom of taping. A positive symptom of Posternetsky may be due to concussion of an excited and tense kidney capsule, for example, with kidney disease, accompanied by significant inflammation or congestive swelling of the renal tissue, pyelonephritis, glomerulonephritis, urinostasis, congestive kidney, conclusion of an inflamed or distended and tendinous renal pelvis, for example, with pyelitis, hydronephrosis, conclusion of calculi located in the renal pelvis and irritation its mucus, and with suppuration of perinephric fibers or inflammation in the perinephritic spaces. Positive symptom of Posternetsky, in all cases, it's a common symptom of inflammation in the renal region. Next, percussion of the bladder. As we discussed with you, how we can differentiate the type of aneurysm, it's a secretory or it's ischemic aneurysm. Percussion of the bladder is carried out after it to the pubis. Normally, after emptying the bladder during percussion and above the zone of gallbladder, you will identify tympanic percussion sound, because it's a cavity with the air is tympanic, and with an increase in the size of the bladder, for example with excretory aneurysm or a tumor of the bladder, a dull sound appears in the suprapubic region. So you can check the presence of urine during percussion above the appendices, and you can go until the change in the sound during your percussion. So that's all for today about semiotic